we are going to talk about different blood products in detail. So first, one of the most common blood product that is used in practice is PRBCs, packed RBCs. What is the rationale for using PRBCs? Number one, for acute blood loss. Best example, trauma or surgery. Second, if the patient is having severe anemia, if you want to increase oxygen carrying capacity, especially in the setting of end organ ischemia, you can transfuse PRBCs. We know that. And next thing is the very important data that 1 unit of PRBCs, that is approximately 200 ml of RBCs, is going to increase hemoglobin by approximately 1 gram per deciliter, and it's going to increase hematocrit by approximately 3%. Very important numbers for exam. And one needs to know the shelf life of PRBCs. Remember, PRBCs can be stored at 2 to 6 degrees Celsius. Optimal is 4 degrees Celsius, which means at refrigerator temperature, not freezer temperature, at refrigerator temperature, 2 to 6 degrees Celsius. It can be stored for a maximum of 42 days. This is maximum. The shelf life typically depends on the compound that you are using as an additive. So, but maximum is going to be 40 days. Depending on the additive, it could be ranging from 21 to 42 days. But remember, the younger the RBCs, better the outcome will be. So, many surgeons will prefer fresh RBCs, recently obtained blood products. That is better. The earlier the transfusion, the better it is. And exams, they might be asking you about something called as transfusion thresholds. So even though this may not be very much high yielding for exams, but this is very important for practice as such. So generally, if the patient is symptomatic, for example, if the patient is having myocardial ischemia, so what is the threshold? We transfuse whenever the hemoglobin is less than 10 grams per deciliter. In hospitalized patients, depending on the comorbid condition, the transfusion thresholds will vary. With pre-existing coronary artery disease, the usual threshold will be approximately around 8 grams per deciliter. Anything less than 8, we can consider transfusion. If the patient is having acute coronary syndrome, the usual transfusion threshold will be 8 to 10 grams per deciliter. And again, depending on the symptoms, it can vary from 8 to 10. For example, if the patient is very symptomatic, having heart failure, hemodynamic instability, then I can keep a liberal cutoff of around even 10 grams per deciliter. If the patient is not having heart failure, not very symptomatic, then I can keep a threshold of even 8 grams per deciliter. In ICU patients, generally in any stable ICU patient, the usual transfusion threshold will be 7 grams per deciliter. Or if the patient is having GI bleeding, which is stable, not hemodynamically unstable, then the usual transfusion threshold will be 7 as well. This is very important for exam. They will ask you for varicose and non-varicose bleed when to transfuse. If the patient is stable, the transfusion threshold is 7, especially for varicose bleeding. Your transfusion threshold is 7 only. Anything less than 7, you transfuse. More than 7, you don't transfuse, because in the setting of varicose bleed, if you have a hemoglobin more than 7 and if you transfuse, it will result in unnecessary increase in portal pressure and can result in more bleeding. That's why these cutoffs should be very strict in certain situations. If you are opting for a non-cardiac surgery, then the usual threshold will be around 8. If you are opting for a cardiac surgery, then your threshold will be approximately 7.5 grams per deciliter. In patients with septic shock, the transfusion threshold will be 9 grams per deciliter. And in oncology departments, generally we keep a transfusion threshold of 7 to 8 grams per deciliter if you are planning for a curative treatment. In palliative care setting, there is no specific threshold, because here the main goal is to relieve the symptoms till the death of the patient. But generally you can keep a cutoff of 9, but that is not applicable in the palliative care setting, because here you're going to transfuse as and when required to improve the quality of life of the patient as far as they are living. Okay, till they die, you have to maintain the quality of life. That's the most important goal there. And what are the additives that are used for storing the PRBCs? First of all, what is the role of these additives? The most important role is going to be anticoagulation. You have to anticoagulate the blood to prevent clotting. That can be done with the help of citrate. Plus, at the same time, you need to supply nourishment to the RBCs to keep them alive. One of the basic additive is going to be the ACD. Sorry for the mistake, it's not APD, it's ACD, that's called as acidified citrate dextrose, which is going to have an approximate shelf life of 21 days. And what are the components of ACD? You're going to have citrate, right? So the citrate is going to help you anticoagulate the blood, and the dextrose that you have is going to support the RBC metabolism by providing the substrate for glycolysis, because we know that RBCs exclusively depend on glycolysis. They don't have mitochondria, they don't have nucleus. They cannot perform Krebs cycle. And that's the reason why glucose is the most important substrate for them, because they're completely dependent on glycolysis. Because they don't have mitochondria, they cannot do beta oxidation of fatty acids as well. And the next additive is CPD, that's called citrate phosphate dextrose. Again, the shelf life of the RBCs with the help of your CPD will be like 21 days, that is 3 weeks only. But here, apart from the citrate and the dextrose, you are having phosphate in addition. This is going to act as a buffer to maintain a kind of an optimal pH so that the RBCs will survive for a longer period of time. And we have another additive called as CP2D. The only difference is you are going to have 2 times the dextrose. The shelf life will not increase, but the number of RBCs that are surviving will be high because you are providing 2 times the dextrose. That's going to improve the overall RBC survival when you are transfusing these PRBCs. The next additive is CPDA. You are going to have citrate, phosphate, dextrose and extra adenine. Because of the extra adenine, that's going to increase the shelf life of the PRBCs to approximately 35 days. Why? Because adenine is going to increase the synthesis of ATP in the RBCs that can help additional survival. And the next additive is SAGM. This is the modern additive. With SAGM additive, the shelf life will increase to approximately 42 days, that is 6 weeks. So what is SAGM? It contains saline, adenine, glucose and mannitol. So here the sodium chloride is going to provide the isotonicity to prevent RBC lysis, plus there is some additional mannitol also that produces local hyperosmolarity that can prevent the osmotic lysis of the red cells. So these are the different additives that you may need to know for exams. If they ask you the maximum shelf life with what additive, then the answer will be SAGM additive. That's going to provide the maximum shelf life of the PRBCs to approximately 42 days.